Assalamu alaikum wa rahmatullahi wa barakatuh. This is Dr. Qaali Hussein. We are recording, doing something a little different today for the Professional Muslim Woman podcast. We are doing a live recorded video with one of our previous guests, Dr. Uzma Syed. She is a board certified infectious disease specialist who is currently on the front lines of the COVID-19 or coronavirus pandemic in New York. Please welcome Dr. Uzma Syed. Assalamu alaikum, Uzma.
Wa alaikum assalam, Qaali. How are you?
Very good, alhamdulillah. Thank you so much for taking the time to join us and update us today on this very important topic.
Absolutely.
Thank you.
Last time we spoke, things were a little bit more stable, to say the least.
We were in a quite a different world last time we spoke.
Exactly.
Yeah. So can you give us a little update on the pandemic, what's going on, where you're at, and then we'll go over some questions that have been posted by some of our listeners.
Absolutely. So that globally, SARS-CoV-2, which is the virus that is causing the illness called COVID-19, has been rapidly growing. Initially started from Wuhan, China, and the numbers have been growing substantially, and it's affected, multiple countries throughout the world. And the WHO has essentially characterized it as a pandemic. And we know nationally that we have significant burden of illness within our country. We have at this point surpassed the number of cases even out of China, over 100,000, close to 139,000 already, with the numbers, rapidly increasing. And some of these numbers are still sort of an underrepresentation of what we actually have in the community and in the nation because of, essentially lack of testing. That when we first rolled out the testing, there was a lot of things that were sort of hindrances that were sort of restricting proper testing in the community. And as you know, New York is really the epicenter of the COVID-19 pandemic and epidemic in the U.S. And we have, a profound number of cases growing on a daily basis, doubling time really going very, very quickly. And we do have more testing that's available now, which is why we are picking up more cases. But, with more testing comes, obviously more disease that's being spread. And we are seeing sort of the burden on the healthcare systems. And being there firsthand, I am seeing, a lot more and more patients that are acutely ill that are requiring hospitalization coming in. Obviously, there are definitely a lot of people that are doing fine, that are able to be sent home and are recovering at home. But being in the healthcare profession, specifically in infectious diseases, I am seeing really that spectrum, the really severe illnesses that are requiring hospitalizations, that are quickly decompensating, needing intensive care, monitoring and ventilatory support, and being on a ventilator, and that are critically ill. So, we are seeing a fair share of that. I'm sure you've seen in the news as well what's happening in New York. As, the numbers grow in New York, we are seeing, a lot of other areas in the nation that are also evolving as the next, epicenters and hot zones, quote unquote, for, COVID-19. And it's really, people across the nation can really learn a lot from New York and see what's sort of headed their way and really start preparing. And I know there's been from healthcare workers to, basically leaders in healthcare and government that are, ringing the alarm. Governors of different states have started really, ringing the alarm and starting to get prepared for what's coming. And different states have already started, the shelter in place. And I think there's a lot that's, out there that can be done to really help with the current situation.
Okay, so one of the things that usually gets brought up is that this is essentially, a cold, right? So a lot of people will get, like 80% of the people will get a mild form of the disease. And the question that usually gets raised is, why do we make such a big deal about it? It's if 80% of the people are going to be affected, why is it that we're making a big deal out of it and telling people to stay in? And can you explain the reasoning?
Yeah. Absolutely. That's a really, really good question that you brought up, because I think the general public, people generally maybe that are not in healthcare, can't sort of comprehend and wrap their head around why it is that we have to take these extreme measures when majority of the population, as you said, may be fine, might be mild. So the thing that's really interesting, so coronaviruses are a virus, belongs to a family of viruses that are respiratory viruses, as we know, and causes usually in most, years, it's a virus that causes respiratory illness, and it's mild. This virus is a novel virus. It's a different strain that we have not seen before, that nobody has been exposed to before, which is why we're having illness from it. And it has a very large spectrum of illness. So you could have very, very mild symptoms. You can have no symptoms at all. So we are seeing that there's obviously asymptomatic transmission of the virus. And then you have the complete opposite extreme, where people have severe respiratory symptoms that are requiring them to be hospitalized and even, intubated and put on a ventilator. So because you have this huge spectrum, you don't know where you're going to lie in that. And we do, know for the most part, the majority of people will recover from this. However, there's a really big percent of the population that is at risk of severe illness. And most of these cases, we always say, as the elderly, the people with pre-existing medical conditions, and the most vulnerable, people whose immune systems might be suppressed. Now, there will always be outliers, and for that reason, it's really important, first of all these parameters and all these precautions in place to protect all of those that are most vulnerable, that are going to have most significant impact from this. Because if we don't do that, then the number of those people and the mortality will be so high that the burden, not only on society itself from mortality, but also the burden on the healthcare system will be so profound that we will not, there'll be essentially a collapse in the healthcare system that won't be able to really participate in all of this and provide for them. And this is something similar that we're seeing in Italy, actually, what's happening at that level. So that's why these extreme measures are really important. The other thing to remember is that although, we are citing, everything that we have right now is based on global information, what we've been following, that doesn't necessarily mean that everything is going to be exactly the same. And again, being in a pandemic, things are constantly evolving. So the information that we have today may be completely, different tomorrow. As you know, a day in a pandemic is equivalent of a week. So things change by the minute, by the hour, by the day. So it's constant evolution. Things are extremely fluid. So even though we are predicting that that's still going to be the model, we are still seeing a lot of outliers. And although, in China, in Italy, and other places, you did have majority of the mortality is in the older population, you will still have outliers, and you will still have young, healthy people and young people who may have some, underlying, high blood pressure, diabetes, that will have significant mortality. So we really want to control all of that as best as we can. That's why it's really important for people to understand that even though they may have mild symptoms, the people that they're interacting with, the people that they can infect, can have much more severe symptoms, which is why it's so important for us to do whatever we can to try to mitigate this.
Okay, so there are reports that we are seeing younger patients being affected here in the States and requiring ICU, as well as pediatric cases. Does that
Absolutely.
indicate a change or a mutation in the virus, or a different effect in the U.S. population? Can you explain that a little bit?
Yeah, absolutely. So I can tell you firsthand from treating patients, especially in New York, where we have the majority of cases. Very early on, I started noticing this trend myself. The first couple of patients that actually I had diagnosed were very young. They were actually in their 20s. And then, there's a mix of patients. And if you look at the reports that are coming out from MMWR, the biggest percentage of patient population that is hospitalized with COVID-19 is in the age group between 20 to 44. So this is actually very different from what the data that we were gathering globally, because we were still anticipating that it was going to be the older age group. So that's one variable that's different. A lot of younger people, have recovered and have done fine, but there is a good mix of younger patients who are critically ill and do require ICU admission and monitoring and are on the ventilator. So it's a very serious illness. What we are seeing is, we knew early on that there's, variation. There's different strains that were, extrapolated from just early, very, very early data from China showed us that, from 3 different cities in China, there was, 6 different strains that they had looked at. But predominantly, there were 2 strains that they were looking at, the S and the L strain. And one of them, the S was early on in China, and then the L was later, outside of China. But what we can tell from this data, what's interesting and what I think is going to be helpful for us as we move forward. Now, granted, we have to keep in mind that being in a pandemic, we are still collecting all the data. So we are not going to have all the answers, but looking back, once this is all over, we will be able to extrapolate a lot of good information and know exactly why things are happening the way that they are. What we can tell is that because, there are a lot of hypotheses out there, but we can tell that there is a lot of variation within the US itself. And I think a lot of that has to do with the composition of the people, the patient population in the US. So China, for example, a very homogenous country where everybody's sort of one ethnicity. And when you come to the US, it's a melting pot. So, there we have all different races, all different ethnicities, and that could be something contributing to why we're having a little bit of a different scenario here than in other countries that we're seeing.
Okay. All right. So I'm going to ask you some of the questions that we have gathered from some of our listeners. They're grouped into different topics so that we can address things a little bit more cohesively. So now we're going to discuss the actual disease itself. How does the virus spread?
So it's a respiratory virus. So it's predominantly spread by droplets. So that means, any cough or sneeze, these respiratory droplets can then, be projected, and they can, once they land on either, if you're close enough when somebody's coughing or sneezing near you, then those infectious droplets can come into your mucous membranes, meaning your eyes, your nose, or your mouth, and then you can catch the virus. The other way is that these droplets also can then, once, somebody's coughing or sneezing, I don't know if anybody's ever seen that picture of somebody that sneezes and you see all of these, droplets that sort of fan out. So all of those essentially then land on surfaces. And so then those infectious droplets can survive on surfaces for a period of time. So if you come into contact with that surface, that could have these infectious droplets on it, meaning you touch a doorknob, you touch a countertop that somebody sneezed right, near there, and it has that particle on there, and then it's now on your skin, and then you touch your face, which is why we keep saying wash your hands, don't touch your face. You can very easily get infected with it. So it's predominantly through respiratory droplets.
Respiratory droplets. Okay. How long does it survive on surfaces? Do we have that information?
Yeah, so we're still gathering. There are some studies that are coming out that are, giving us some information on that. There were studies that were giving us different determinations based on what kind of surface was being tested, whether it's steel, wood, or cardboard. But essentially, we know that the infectious particles can live on surfaces for several days. Now, a lot of it has to do with environment and what you're specifically looking at. But we know for a fact that they can live on surfaces for several days. So that's why we also encourage disinfecting of common, surfaces very frequently, whether it be in a household or a healthcare setting.
Okay. So for those who are infected, what criteria do they have to meet to be declared disease-free?
So that's an interesting question. A lot of this, again, based on CDC guidelines and recommendations from WHO and, from our local public health authorities, based on if you're looking at in the healthcare setting or in the community. So essentially, to be considered disease-free from any infectious disease, the main things that we always look for is, resolution of symptoms. Means that are you symptom-free? Meaning, has your fever gone away? Has your cough, your shortness of breath, has all of that improved? The CDC had given guidance early on that especially in the healthcare scenario, that for patients that were admitted to the hospital and you wanted to think about maybe stopping their isolation and saying that, okay, now we can declare that they don't have this infection anymore, there's certain criteria that had to be met. Not only did they have to be symptom-free without a fever and symptoms, but we also had to check to make sure that the virus had gone away. And how do we do that? The testing for this virus, respiratory virus, is a swab that we do, a nasopharyngeal swab, and it checks, for the virus there. So we would have to do this swab to make sure that there's no virus that was detected. And initially it was required that we had to do 2 swabs that were at least 24 hours apart to prove that, in fact, this was adequate, collection that we did, that, the sample that we had was good, and that we can, on 2 separate occasions, 24 hours apart, prove that there's no further virus there. So usually that was what was recommended initially. For people in the community, it's essentially, we just base it on the fact that we know for the most part that the incubation of the virus and the illness is average about 2 weeks. So that's why we tell people that, you want to stay home if you're not feeling well, stay home for roughly about 2 weeks, quarantine yourself. You should be without fevers at this point, and you should be without any symptoms. And hopefully by this point, we can pretty much assume that, at this point, your illness is over and you should not be infectious. Again, there's a spectrum of illness, there's a spectrum of symptoms. So we definitely know that people that it has been shown in studies globally that people that have more severe symptoms can be shedding the virus for a little bit longer. People that have milder illness can be shorter. We're still gathering more data, so it's very fluid still, but that's in general. We usually like to say that you should be without a fever, like any other, like influenza and any other respiratory viruses, you should be without a fever and symptom free so that we can say adequately that you're not necessarily infectious anymore.
Okay. And once a person has recovered, are they still able to spread the virus?
Yeah. So that kind of ties into the last question that I just said. Again, very complicated because we're dealing with a novel virus that has such a wide spectrum. Like I said, we have people that are asymptomatic, we have people that are very symptomatic, and then we have case reports that are telling us that there's prolonged viral shedding. So it's really hard to tell right now. But again, based on how severe the symptoms were, if somebody was very, very ill and in the hospital in ICU or even critically ill in the hospital, the more severe the illness, it has taken them that much longer to recover. So their recovery may be from up to 3 to 6 weeks, where somebody who is very mild, who was fine at home and didn't need to go to the hospital, their recovery time may be 2 weeks. So, even after a person is recovered, based on where they are in the spectrum, they may still be, transmitting the virus, and it's really hard to tell. But for the most part, if you're without a fever and you're without symptoms and you're feeling better, I think you should just continue to practice, good hand hygiene and cough etiquette and, those things to really prevent any further transmission.
Okay, very good. Do we have treatment for COVID-19 at the moment?
So that's a great question. I know there's a lot out there in the media. There's a lot of talk about this, especially recently. As of now, there is still no FDA-approved medication for the treatment of COVID-19. There's a lot of clinical trials that are going on nationally and internationally, globally, on different treatment modalities for medications that we've already had in place for different medical conditions and seeing if they have any utility in COVID-19. But as of right now, there's no drug that's been FDA approved to treat this illness.
Okay. And I think the next question is along the same lines: is can it be cured?
Right. Yeah, we don't have anything that has shown that right now. The clinical trials, we're hoping for some good data out of the trials that are going on nationally, especially to see if we have any leeway on that. But as of right now, there's no information on that.
Okay. Can you speak to the recommendation that NSAIDs should not be taken if a patient is found to have COVID-19?
Right. So there's a lot of conflicting data on that. A lot of the large organizations have looked at, there's studies coming out on a daily basis, right? People, because this is a pandemic, people are trying to gather whatever information that they have and disperse it as best as they can. A lot of these studies are still in peer review. A lot of these studies that are even published don't, necessarily meet that we would normally. Are they significant? Do they show that there's significant impact? So the data on this is still on the fence, but for the most part, it's something that, if the patient, essentially, if somebody is not, on these kind of medications regularly that needs it for any particular reason, for the most part, people are encouraging to use a different class of, antipyretics or, fever reducers such as Tylenol, anything else, as long as you have no other reason that prevents you from taking that. But we still need a lot more information to say that there's definitively a link, but that's really what's being recommended right now.
Okay. All right. So this other question, I want you to speak to it in terms of population-based, because I think it also ties to the fear that a lot of people have based on the severity of the disease and the numbers. And the question is, why is it lethal? Is it truly a lethal disease? And, why all the hype about it?
Okay. So, into this really well about the spectrum of the illness. So, majority of people, we're still seeing are going to have recovery. So even globally, you'll see, although there's so much impact, so many people, over 500,000 people affected by this illness, there's still a majority of those people still have recovery from it. But it is, because it's a novel virus and it is a pandemic, we do see a significant amount of deaths from it, globally, and same thing here. So I think, the thing that ties into the lethality is a couple of different things. first, it's a novel virus, so we are still learning a lot about it. Second, there's really no treatment for it because it's a new virus that we've never been dealt with. Again, none of us have immunity to it because we've never been exposed to it, so that makes it a little bit difficult. And as I mentioned before, depending on how severe, really going to predict, how you do with it. People with underlying medical conditions whose immune system is suppressed, who are older, 70, 80, 90 years old, they're having far worse outcomes than, people who have no underlying medical conditions and that are younger. And so, the thing that we see with this is that the lethality, really the mortality, as we can say, increases with these risk factors. Now, the one thing to know is that, the case fatality ratio, which we always talk about, in the science world, that's something that that's basically how many people, the number of people that have been affected by the disease that have died, divided by the overall number of disease burden, right? So we can't really calculate that. There are, hypotheses of what it looks like, and predictions of what it looks like. But while we're in the middle of a pandemic and an ongoing pandemic, we can't necessarily calculate that. That's something that we're going to have to do retrospectively when everything is done. But the lethality of it is really because of the severity of illness that happens and, the effect that it has on, the lungs and multi-organ, failure once you get past that, because it can affect your lungs, it can affect your kidneys, and everything essentially shuts down. And that's why we get to that point where it progresses so rapidly, and we don't really have treatment modalities for it.
Right. Okay. What are the expectations of for COVID-19 in the next coming weeks?
So we are expecting, New York, this varies based on, where we are nationally, but and even globally. But, as the burden has been intense on New York, and, New York City and the boroughs are getting hit really hard, and Long Island as well. And everything is sort of moving from west to east, and, with more and more reports every day. But we are predicting that there's going to be, we're going to be peaking in the next, 2 weeks or so. Nationally, we are seeing more and more, reports coming out of many states, as Louisiana, Michigan, Illinois, a lot more cases being reported nationally. And so we are expecting to see that there's going to be increased numbers as the testing ramps up across the state, and as the illnesses, people, have been exposed already, and now we're seeing, that they are past that incubation period, so they're going to be presenting with the illnesses now. So we are definitely expecting to see a lot more cases in the next few weeks, and that's really what we have to be prepared for.
Okay, all right. So this is a really good question. So we are asked to stay home until the symptoms are severe. When is it appropriate to seek medical treatment? What symptoms are considered severe?
So that's a great question. I get asked this frequently. That's a very, very good question. Again, really important, because I mentioned before that you have such a wide spectrum of illness, and what we're trying to do from the healthcare perspective as well, and from the community perspective, is to keep people that have very mild symptoms at home, so that we don't keep bringing people to the ERs and then burdening the ERs in the sense from the people who are acutely ill, who need to be seen right away. So if you're, just have a fever and a cough and you're feeling fine, otherwise we encourage people to stay home, right? But the things that you want to look for that should alert you to, maybe now it's the time that I need to seek medical care. Now is the time I need to call my doctor. Now is the time I might need to go to the ER. So the most important thing to really look for is shortness of breath. And by shortness of breath, I mean, because the virus very commonly will give you shortness of breath. That's a very common symptom. But the thing that should really be the marker of this is if you're having a lot of difficulty breathing with the most minimal activity. So something that is not normal for you, with very, very minimal activity that you may do on a regular basis. You're getting really winded. You can't take a few steps. You can't do anything, and you're feeling really winded. That should really alert you that you really need to seek medical care.
Okay, very good. What is the prognosis once a patient develops severe chest pain?
So chest pain, it's a very it's very individual. So I think you have to look at it. We can't just tie chest pain in, specifically to COVID-19. So, as there's a spectrum of, symptoms that people can have. Most common is fever, cough, and shortness of breath. Based on your underlying medical conditions, if you're a diabetic and if you have cardiovascular disease and you're having chest pain, that could be very, very serious and severe, prompting, emergency room, evaluation, where you might be having a heart attack. You might be having, you need to be evaluated. people that are generally healthy, normally people that have pneumonia can have, some chest pain just from having irritation. So that's a really, it's not really correlating specifically with the illness. So if you're having chest pain of any kind, I would definitely recommend that you speak to your medical care provider, your healthcare provider, to help assess and triage it, because it varies based on your age, varies based on your underlying medical conditions, and what other symptoms you're having.
Okay, and I've gotten asked this question multiple times, and I think we can, it's probably still up in the air. If someone recovers from COVID-19, can they get reinfected?
So that's an interesting question, and we don't have all the answers still. So that's going to be, my plug for everything, because as I mentioned, we're in a pandemic. There were some reports out of China early on that did show that there was several patients that were released from the hospital and then readmitted again with symptoms, even though they had been, shown to be free of the infection, whether it was with the swab or, without any symptoms. So there's a lot of theories in that. It's hard to tell right now if there is reinfection going on. We need more data. It's always possible that, the testing was done inadequately. It could have been a false negative. It could have been a sample error. There could have been many, many different things. Again, like I mentioned, some people are shedding the virus for longer than others. So it could have been one of those things. We don't know. We have to really wait to gather more data to know specifically.
Okay. All right. So the next question, with the first infant mortality or infant fatality reported, how do we take care of the young ones, and what are there any specific risk factors?
So as of now, we still, I know that was very recently reported, and we need more information specifically to that case to see what were what was exactly the scenario in that caused that. Early on from China, we knew that there really wasn't a lot of, reports of children or even infants. There was one or two case reports that came out very, very early that showed that there was, an 18-hour-old infant that had tested positive, and very early on, there was this concern, could there be some transplacental, transmission in utero? Could that be the case? But then they did some data collection and they found out that it was actually transmission after the infant was born. So they were in contact with somebody that had it. So up until now, there really wasn't any theory that this was something that was a risk factor, for infants or in utero. So as I mentioned, we need to get more information on this. I think we're going to be learning a lot more about this as days go on. We have to know specifically to this scenario, was it something that applies generally for everybody or not, or was it an isolated incident? But the thing that we have to really focus on is the same thing that we've been stressing all along, is that we have to continue with, good hand hygiene, cough etiquette, 6-foot distance, and, social distancing, because really what we know about the virus is how it's transmitted and how we can prevent that continuous, transmission. So whether it be in a healthcare setting or at home, in the community, we have to protect those that are most vulnerable. And that's really what we should focus on.
Okay, last two questions on the disease, and then we'll go on to our next two big topics. So one question is, what are your thoughts on palliative care in these patients, especially when they're critically ill?
Right. So I think that's something that's being discussed very much so right now. And again, I think that's something between the primary care providers, the home environment, the family unit, and the critical care physicians, and infectious diseases as well. We talk about this all the time. So it really depends on the patient and their underlying medical conditions and what state they're at. But I think it's very important to have these conversations early on. It's really important. We always advocate for this as physicians, to make sure that patients' advance directives. What are their wishes? You want to know all these things before somebody gets really sick and gets to that stage. So I think it's important to have that team approach to this. Not only is it, critical care and infectious diseases, but, palliative care should be part of, this team. It should be a multidisciplinary team approach, regardless of what the outcome of the patient could completely, recover and do better. That's fine. But, everybody needs to have that conversation early on and stay connected and communicating the whole time.
Right. And I'll just add, from a critical care standpoint, that is one of the things that's usually discussed during the overall care of that patient, especially given their overall comorbidities and their likelihood of survival, and whether they're going to have good quality of life after they recover from this. Right
Absolutely.
now, I think I posted a Washington Post article the other day where they interviewed multiple physicians.
Hmm.
Hospital systems are getting overwhelmed, and
Hmm.
ICUs are getting full. Operating rooms are being turned into ICUs. And so
Absolutely.
some hospitals are considering having a blanket DNR for all COVID patients, especially if they're
Right.
critically ill. So it's
Right.
nothing set in stone, but it's a conversation that is starting.
Yeah.
And I think that's a good thing to have in mind, so that, you know, if you have a family or one of your loved ones is in the hospital, that having that conversation early on isn't a surprise, because we are already discussing that
Exactly.
at
We're getting
at
to
the
that
onset.
stage where we're having to make those tough decisions. So it's really important to have these conversations early. And I think that's a very important topic.
Okay, and this question I've gotten multiple times on multiple different platforms. When is it going to end?
If only we had the answer to that. So unfortunately, we don't know. There's a lot of speculation. Given that we are in the midst of this, we just sort of what we have are predictions for sort of day to day, week to week. Nobody really knows if this is going to be, traditionally pandemics. You can't compare a pandemic to what happens in a seasonal, illness. So you can't compare COVID to influenza. You can't. So everything is very, very different. There's certain pandemics that had their peak in the summer times. The Spanish flu, for example. So everything is very, very different. We have to wait and see. There's speculation that maybe, in 2 months from now things may slow down. We don't know. There's a good chance. There's a chance that it could go into the summer. We just have to wait and see. We have to see. We have to take the data, take the science, and go with it. But it's too early right now for us to know for sure.
Okay, so now I'm going to get into the myth versus fact topic.
Okay.
I
Okay.
think I think this will be very helpful. And I'm sorry if some of these may be a little entertaining at the same time. Number one, is it true that drinking hot water regularly can protect us from this?
Yeah. So there's no scientific data on that, unfortunately.
Okay.
As you know, the virus is transmitted by droplets and, these infectious particles that are around. So really, that's why we keep stressing so much on hand washing and not touching your face. And these are the things that we know definitively prevent transmission of the virus.
Okay. Is the virus resistant to heat? Like if you were to move to a really
Yeah.
hot area, is that going to make it
So
go away?
yeah, so that's not been proven either. I think there's a little bit of confusion because we know that there's different things as really extremes of heat that are not physically possible to live in, and UV light and things like that that we know are used for sterilization and killing of some of these viruses. But that's very different from environment that you live in, and that's not been proven yet because we know that there's cases worldwide. It's a pandemic, so you have Singapore that has cases. You have people, you have all over the world is being affected. There's really no place that you can say that, oh, this is only, a cold climate virus or anything like that.
Okay. Can vitamin C help prevent or treat COVID-19?
So that's really interesting, actually. There's when I was mentioning before the clinical trials that are going on, there's been a lot of case reports that have come out globally about the use of vitamin C, and there's actually ongoing clinical trials with that right now to see if intravenous can do anything for these patients that are critically ill in the hospitals. Again, we're still gathering data. We don't have an answer for that as of now. There's really nothing that's been proven to prevent it or to cure it, but that is something that's being looked at.
Okay. And I think this is our last one on myth versus fact. There are some recommendations online that says that eating alkaline foods is helpful and will treat the virus because the virus has a low pH. Is
So
there any
that's
truth to this?
Yeah, unfortunately there isn't any truth to that. And it's interesting how these different, myths come about. I don't know if it's extrapolated from some bits and pieces of different conversations that have maybe then led into different things, but there's no pH. What we know about the virus is that it's got this lipid envelope. We know it has these proteins, these spikes. We know how it attaches. What receptors it attaches on. We know this, and we know, we've studied it under microscope, and we know that the thing, like I mentioned before, soap and, water and, these, alcohol-based sanitizers are really good at, breaking down that envelope and breaking down that virus. So we know that's what breaks it and that's what kills it. But, this pH-based diet is not correlated with this. Yeah.
Okay, thank you so much for answering those.
Yeah.
All right, so our next group of questions is on protection, prevention, and coping. Okay, so the first question is, what is the appropriate precaution for COVID-19? Is it airborne or droplet precautions?
Okay, so we know from respiratory viruses, in past, including coronavirus, that, they're transmitted by droplets, as I mentioned before. And so the standard precaution is usually contact and droplet. For patients that are undergoing any type of procedure that might have a risk of aerosolizing these droplets, meaning that extending them into the air environment where they can be, circulating and be more infectious to people. So some of these scenarios can be if somebody's getting intubated, getting put on a mechanical ventilator, if somebody's being aggressively suctioned, if there's bronchoscopy ongoing, if there are different types of things that are going to propel these, droplets and keep them aerosolized, then that's when you definitely have to have, airborne, precautions for that. And so there's different types of masks and different types of environments in which we say that. But for the most part, if none of that is going on, then it's, contact and droplet.
Okay. What is your stance on the current guidelines for PPE?
So, there's been a lot of changes on the recommendations from the CDC as we've had more and more cases globally and nationally. A lot of the criteria and the recommendations has changed. Some of this is based on what we know about the virus, although we are still collecting more data. And some of this is essentially based on, and the recommendations keep coming out based on supply and demand. And, and they will clearly say that if you don't have this, then this is acceptable, then the next is acceptable. So for the most part, they are recommending basically just what I had said before about contact and droplet and airborne for any high risk procedures, patients in the ICU where you may be, unstable things happening where they may need to get intubated right away. And, those kind of scenarios. And otherwise, everybody else is essentially the standard precautions of contact and droplet.
What do you think of the safety of reusing and sterilizing these masks, the N95s or surgical masks?
Right. So and CDC had given some guidance on the reuse of N95 masks. Again, clearly stating that, when you're in a situation where, supply is limited and, whether you be in the US or outside, where you have to, have the best protective measures in place to prevent, transmission. They had found that, that these N95 masks, there's guidance on it that you can have extended use of these N95 masks. Now, there's a lot of different things, criteria in this. So to have proper and adequate reuse of the mask, you have to make sure certain things are there. So one of the most important things is that the fit of that mask should still be adequate, right? So if you're not getting that good seal, then it's not doing its job. Then obviously it can't be reused. You have to make sure that that mask itself is not soiled, because if it's soiled and contaminated, then you're just going to keep, transmitting that virus to yourself or to other people. So then you can't reuse it. But other than that, if you are extremely careful in donning and doffing, and you use what's actually a really good practice is to use a regular surgical mask on top of the N95, which you can assume that one, is potentially could be contaminated, and you discard that one when you're doffing, and then you remove your N95 and very carefully store it before the next use, that you can say, and without touching the front of that, then that essentially, that area is still somewhat sterile and not contaminated, and that gives you, longevity. So, you will get more life out of that N95 mask.
Okay.
And then obviously I had mentioned before about the UV light that's being used to, sterilize these. And that's another method of prolonging the use, just to have that scenario that this protection is better than having no protection for those extreme scenarios where you are at risk of aerosolizing.
Okay. And you probably might not be able to answer this, but is it safe to use an N95 mask, the same one, for a week?
So actually, CDC did give guidance on this, and they had said that it can be used for up to about 5 days. Again, I think people have to be very, very careful, and apply the criteria that I had said before. You have to make sure that you're being very careful in doffing, that you're being very careful in storing these, that it's not distorted, that you're still getting that seal, if any, and it's not that it's not soiled, if it's contaminated. So if any of those things happen, really you cannot just keep using it for an extended amount of time. You need a new one.
Okay. If there was not no concern for a PPE shortage, how would we best prevent infection and transmission when taking care of these patients?
So I think, what we've learned in all of our life, in medical school, in, residency, internship, residency, fellowship, training throughout, we've had very strict infection control measures that we've all held to a certain criteria, a certain level. And we do these practices to really have best outcomes, in the healthcare system. So what's being done now is, the best case scenario given the circumstance that we're in. And like I said before, we're going to have to wait to get all the data from what's happening right now to see were these practices effective or not. But that being said, being very cognizant of that, making sure that you are, being careful with, like I mentioned, the donning and doffing and whatever PPE that you have, that you are using the best practices with what you have right now to prevent any further transmission.
Okay. And the next question follows this previous one. How much exposure are people getting with the current recommendations?
How much exposure in healthcare, you mean?
Yes. How much exposure are healthcare workers getting
Right.
with the current recommendations?
Right.
Do we have
So
those numbers?
yeah, so we don't have that data yet. We're, like I said, we're still in the middle of it. You will hear cases of people getting ill, healthcare workers getting sick. They're still trying to figure out specifically if this is just exposure from, specifically tied to healthcare, or is some of this related to community, what's happening in the home environment, or, the exposure. So we have to gather all that data and come up with our numbers, like what is the percentage that we're looking at. There's more numbers globally, but again, they're still going through Italy, Spain, they're still going through their, their pandemic currently. And so we have to wait to get all that data.
Okay. And do we have any from previous cases, what an acceptable healthcare worker infection rate?
So this, I personally don't think that there is an acceptable healthcare worker. There, it should really be zero. I mean, if we are using our best practices, the goal is to prevent transmission to patients and to other healthcare workers. Really, that's our goal, and that's what we need to focus on moving forward. And how we can tighten that. We are in unusual circumstances right now, as you know, nationally, and with limited resources, and trying to do the best that we can. But we have to really have it at the highest level and the best standard that we possibly can.
Okay. All right. Last two questions. 26. That's the number of questions I have so far. I know. I'm sorry. It's a lot. I will let you go in just a second. Can homemade masks prevent transmission?
Okay, so there's a lot going on right now with homemade masks, people really stepping up, trying to help out because of the immense shortage of PPE that's out there. So obviously these are not approved as masks that we would be using in the healthcare scenario. The thing to know is that, so these masks are good to use for people that might be ill in the community. So in the household, you might have a family member who is actually sick with COVID, and the mask is good to contain their infectious droplets. So you want that member in the house to keep the mask on, because then, they're containing all those droplets and limiting the amount of spread that there is. In the scenario for the healthcare worker, in the scenario where, worst case scenario where everything is gone and you have no masks left, or you have, this N95 and you have no surgical mask left to protect it with, it's like extreme scenarios. You keep going down to the next thing that you have. So in that scenario, you could use that as a cover maybe for the N95 to protect that N95. But really, it's a matter of, using the best resources that you have, trying to extend them safely as much as you can, and then going to the next tier.
Okay. All right. And the last one. And this has to do with coping. And I think, we need this more than anything else right now. For healthcare workers on the front line, such as yourself, what is your advice for dealing with the anxiety of being exposed?
Yeah, so that's a great question. And this is something that unfortunately we're facing quite a bit right now in New York and throughout the US and throughout the world, actually. I always say this that, physicians, nurses, anybody in healthcare, PAs, we've all been trained to work really well in in high stress environments, right? And we know we're trained this way, we're built this way to function really well in these type of environments. The problem that we're having now is not only is it, the novel virus, not only is it the speed at which we're seeing the volume of patients coming in, the speed at which this is happening, and also the acuity of the patients that are coming in. So they're very quickly, decompensating, and, they're requiring hospitalization. So all of these variables are creating, an environment that we're not normally used to. And then on top of that, you have so many different layers of breakdown that's creating a lot more anxiety. The shortage of PPE, the changes in our practices. So we've been taught, like I said, we've had these very strict infection control measures forever, and now we're sort of modifying things based on, what's available to us and what we can do best in this scenario, while still providing adequate care and preventing further transmission. So all of these different things create an environment where there's heightened anxiety, in addition to obviously how sick our patients are and we want to care for them. So I think, it's really important for all of us to, whatever method works individually or as a group, to really build a community, lean on your friends and family, have that support system, show up at work, but, know that, what we have right now is, we have to make sure that we are protecting ourselves, that we are protecting our patients, that we're providing the best care that's possible, and to really take it one day at a time. And I think it's really important, it's a tough situation that, healthcare workers are in, especially being in the front line, but we have to remember, the things that we do know is that it is transmitted by respiratory droplets. So, if we have masks and we have eyewear and we have gowns that and we are very, very good about our hand hygiene, washing thoroughly before and after every patient encounter, and not touching our face, and doing all these things that, that should, we should have some peace of mind knowing that that should limit the amount of exposure. But we have to remember to still have these practices, no matter how much volume is coming our way, how many patients we're seeing, and how much is going on in between, whether it be a nurse or a physician. We have to remember to still, pause for a second, put on that PPE properly, don and doff properly, and, wash your hands and do everything adequately so that, you are not endangering yourself and others.
And one of the things that I want to add to that, thank you for that excellent answer. One of the other questions that followed this was, how do you keep from living in constant fear? And one of the things that I want to acknowledge, in this discussion, is there's also a constant fear of all the bureaucracy that is dictating how we practice. The shortage of PPE is understandable. We, as a system, as an entire healthcare infrastructure, we were not prepared for this. But at a smaller level, at hospitals, you're having, administrators kind of dictate who gets to protect themselves and who doesn't. And a lot of healthcare workers are feeling like they're being basically their health is being jeopardized. So one of the things that is actually happening on social media is there are a lot of groups, especially around this pandemic of COVID-19, that are sharing their stories, that are sharing their experiences. And I think that has been one of the most helpful things that I have seen is, find a way to express all this, whether it's through writing or through talking to someone, to share all these things, because this is not normal. None of us are used to this. We do trauma and disaster planning, and even do ICU and take care of the most critically ill patients in the hospital. And my colleagues in that field, who are also on the front line and dealing with a lot of these patients, are feeling burnt out, are feeling fear and anxiety. And I think it's important to have, whether it's through social media, through family, through other colleagues, to have a support system to express all these things and not let it build up. And hopefully once we are over this pandemic, we can come together to find a solution so that we're not in the same situation were something like this to happen again.
Absolutely. That, I mean, you just hit the nail on the head with that because, there's so many points you just brought up in that are so relevant. I can say for myself personally, I felt the same way where, I mean, as you mentioned, we all have, high stress level careers, right? But we've never been in this kind of situation where it's really like, the worst, like a perfect storm essentially. And so for me personally, I will come home, I, have my good days, I mean, there really aren't good days, but, the better days, and then, the worst ones. And, I find tremendous relief from just writing, just writing my feelings down. I have a lot of physician friends that are painting, whatever way that you can release, some of that, whether you talk to somebody, I think you have to find some way of coping with it. And I think, as you mentioned, there is so much we have learned from this of how essentially ill-equipped we've all been, whether it be, from a physician perspective, an industry perspective, a national perspective, and we are going to come out of this, knowing that we do not want to have this scenario ever again.
Ever again. Exactly, exactly. Well, Dr. Syed, thank you so much for giving us a moment of your time. We wish you the best of luck. Inshallah, we will pray and make dua for you and your family and your patients, and inshallah, we will get through this.
Inshallah. Thank you so much. Jazakallah khair.
All right. Thank you so much. Assalamu alaikum.
Wa alaikum assalam.